Hello, my name is Andrew Brino,
And I'm Emily Beneviat.
and our project is on the connection between multiple sclerosis and Crohn's disease.
So for our presentation, we've split our slides into 3 different sections. So we're going to first talk about multiple sclerosis, and then Crohn's disease, and then the connection between the 2 diseases.
Just as a quick introduction, we want to talk about why we chose this topic. My brother last year was just diagnosed with Crohn's disease, and one of the first questions that really solidified the fact that he had Crohn's disease, the doctor asked if my brother had anyone in my family who had multiple sclerosis, which my aunt does. So it's just kind of this weird kind of thing that my brother went through where a kind of concrete diagnosis for Crohn's disease was with the connection of multiple sclerosis. And so we just kind of wanted to explore that and why that is. Okay, so we're first going to talk about multiple sclerosis, more also known as MS. So multiple sclerosis is an autoimmune central nervous disease and is characterized by demyelinization and the severed terminal axons in the central nervous system. It also causes lesions in the central nervous system. There are 3 main stages: the preclinical, the relapsing remitting, which is periods of pain and demyelinization, followed by recovery, and then it just goes back and forth. And this makes up about 85% of all patients with MS. And we also have the progressive clinical stage, which is just a gradual decrease in myelinization over time. And it is caused by both genetic and environmental factors. Okay, so some of the symptoms include optic neuritis, which is blurred vision with associated pain, partial myelitis, which is the extremity and torso weakness and impaired sensation. This is a really big one. It can have implications on walking and doing common tasks. And also some brainstem syndromes are also affected as well, such as vertigo and hearing loss. The mechanism of MS can be kind of complicated, but it is first initiated with the fact that the central nervous system is immunoprivileged. Basically means that a lot of the energy from the immune system is first dedicated to the central nervous system. It is a very delicate system, and without it, it can cause major issues within the brain and the spinal cord and all that kind of stuff. So it's really important that it is immunoprivileged. Also, it's worth noting that some of the central nervous system proteins are tumor-specific antigens, just so that if a tumor does happen, it's more easily combated by the immune system. Also, it's really interesting to see that every person with or without MS has the same amount of T cells dedicated to myelin antigens. So some of these CNS proteins are not expressed by air in the thymus. So just in case there does happen to be a tumor that gets into the central nervous system, it can more easily fight it. MS leads to the breakdown of the blood-brain barrier. That is a big connection between the central nervous system and the rest of the body, and it really protects the central nervous system from a lot of pathogens. So MS does lead to the breakdown of it, which can cause a bunch of issues and be immunocompromised as well. These T cells get activated in the central nervous system in individuals with the compromised blood-brain barrier. So that is kind of how the T cells then further attack the myelin sheaths of the central nervous system, which causes all the issues and symptoms that were listed before. And this does really have a lot to do with activated T cells, cytotoxic T lymphocytes, Th1 helper cells, Th17 helper cells. They all facilitate the breakdown of the myelin sheaths in the central nervous system. There are a couple different treatment options. The first couple are for the relapsing remitting MS, which are the ones where you have periods of pain and then periods of remission. The first one are monoclonal antibodies that attack different CD molecules. It just inhibits the reception between the T cells and the B cells. So it kind of helps with the decrease in activation of T cells against the central nervous system. And then we also have phosphate inhibitors or receptors. These are shown to decrease annual relapse rate, but also they help decrease the activity of the kinase and when the T cells get activated. Clinically isolated syndrome is characterized by one instance of the decrease in myelin sheaths, and it caused all the pain and the symptoms that were listed, but is also known as an early sign of MS. And there is an interferon beta treatment, which is known to downregulate the MHC presentation. So that really does decrease the activation of T cells and basically inhibits the activation of MS.
So now we're going to talk a little bit more about Crohn's disease. So what is Crohn's disease? It's a chronic inflammatory intestinal disease that will affect parts of the GI tract. And there are periods of flare-ups and remission, so sometimes the gut is more inflamed than others. And it's transmural, meaning it affects all layers of the intestinal wall. And it has often been linked by environmental and genetic factors, as well as the immune system response and changes in the gut microbiome. Some of the major symptoms for Crohn's disease are fatigue, abdominal pain, diarrhea, weight loss, skin and joint inflammation, and eye redness. So now we're going to talk about the mechanisms for Crohn's disease. We're going to start with cytokines. So in Crohn's, there's an elevated level of inflammatory cytokines, things like IL-12, and IL-36 also induces IL-6, which is a major inflammatory cytokine that we've learned about. So there's a dysregulation of components of the immune system in the mucosa, which can lead to hyperactivity of T cells. So if we think about Th1, which usually has to do with targeting intracellular pathogens, this overactivation of cytokines actually makes it target cells in the gut and cause damage. And it can also activate macrophages in the gut, which lead to even more inflammation and tissue damage. And then these cytokines can also lead to a decrease in the number of Treg cells, which help suppress the immune response. So if Treg can't work to inhibit T cell response in the mucosa, it will lead to inflammation, which is especially common in children. So here's actually an image from one of the journal articles that we were using about Crohn's disease, highlighting the different T cells and cytokines that are involved in the gut with this mechanism for inflammation. There are also other mechanisms like the humoral response, where plasma cell differentiation will happen through cytokine IL-2 activity, and then convert naive B cells to express granzymes, which can cause epithelial damage. And also just looking at the gut, so the microbial-associated molecular patterns are recognized by receptors to activate immune cells, which once again contribute to the inflammatory response within the gut. So I also want to go over some of the treatment options. So medications are used, but none of the drugs are proven to be curative or completely safe. So there are immunosuppressant drugs like thiopurines and methotrexate used to maintain remission. There are also anti-TNF drugs, and TNF is a pro-inflammatory cytokine, so they use drugs to inhibit that. And then monoclonal antibodies is more recent, and it targets specific patterns of inflammation. So a fully humanized monoclonal antibody will target like P40 subunits of different cytokines like IL-12 and IL-23 to try to stop some of that inflammation. There's also dietary changes that can be used. Often there's iron, vitamin B, or B12 deficiencies, so using supplements can help regulate some of that. And people are encouraged to have diets that are diverse, but if people have really significant inflammatory problems, low saccharide diets can be helpful. And the last treatment option is surgery, which is usually the last case scenario. So we have a bowel resection to remove really severely damaged portions of the intestines, as well as a stricturoplasty, which will widen narrow sections that are caused by scarring to help induce remission, lower inflammation, and lead to mucosal healing.
Okay, so now we're going to explore some of the possible linkages and the connections between these two diseases. There is this idea of a subsequent diagnosis. There's a higher chance of developing multiple sclerosis if in someone that already has an IBD. And IBD is an inflammatory bowel disease that includes Crohn's disease and ulcerative colitis, both which are inflammatory diseases just in different regions of the gut. There also seems to be a sex linkage between these two. Multiple sclerosis is seen in more women than men in a 3-to-1 ratio, and women also have a slightly higher chance to develop Crohn's. But more men are likely to develop IBD after having MS. There seems to be also more men that have both multiple sclerosis and IBD at the same time as well.
So the complete connection or mechanism behind what really links these isn't completely understood, but there are some ideas if we look at the genetic patterns. So IL-23A mediates both CD4 and CD8 T cell function, and this interleukin has been linked as important to the pathophysiology for both of the diseases. We can also look at the INFG gene, which regulates Th1 and Th2 cells in both diseases. And the gut dysbiosis, which is basically just dysregulation of the gut microbiome, from Crohn's disease is linked to the onset and progression of MS. And the GPR25 is a G protein coupled receptor expressed in natural killer cells and T cells, shown in risk of multiple sclerosis and Crohn's disease. What we also found really interesting while we were researching was seeing how many complications there can be between the two diseases. But like there's a genetic link, but the treatments for both of them can actually end up causing problems within each other. So, for instance, interferon beta, which treats MS, is linked to increasing the severity of Crohn's disease because they activate dendritic cells and natural killer cell activity, which in the gut can lead to damage and inflammation. And the TNF alpha antagonists that are used to treat Crohn's disease actually are seen to worsen multiple sclerosis. That mechanism isn't completely understood, but there is some evidence that it lowers CD8 plus proliferation in MS.
Thank you for watching, and here are our references.